We are live, ma'am.
Good evening. Welcome to iFocus Lecture 45. Today we have Dr. Garvit Bhutani, who is currently working as a consultant at Center for Sight, New Delhi. He has graduated from PGI Chandigarh and has done his fellowship in cornea and anterior segment from LVPI Hyderabad. He has numerous publications in peer-reviewed journals and presented in various national and international conferences. Today, he will be speaking to us on high-risk keratoplasty and corneal graft rejection. Welcome, sir, and over to you.
Thank you, Harika. Thank you, organizers, for giving me this opportunity to present. Screen slides visible. Harika, are my slides visible? Am I audible?
So, would you like to share it again?
Is it visible now?
Sunilji, are you there?
Sir, can I help in any way? Dr. Bhutani, your voice is not coming.
Is it audible now?
Hello,
Yes, sir, you're audible.
and my slides are visible.
Yes, sir. Yes, sir, perfect.
Okay, so in today's session, I'll be taking you through what exactly do you mean by a high-risk keratoplasty and how do you define a corneal graft rejection? How does it differ from corneal graft failure? And how do you identify a graft rejection? And then subsequently, how do we manage such cases? So first of all, what do you mean by a high-risk graft? The collaborative corneal transplant study, which is one of the biggest corneal transplant study till date, defined high-risk graft as two or more quadrant of vascularization and or a previous history of rejection in a corneal graft. So the two photographs you see on your right hand side are the ones which I'll put as high-risk graft because of the corneal vascularization, and the second one being a failed graft. So keratoplasty was the first keratoplasty was performed by Dr. Edward Zerm long back in 1905, and in these 115 years, we have come a long way in keratoplasty. The first keratoplasty performed by him was on a patient who had bilateral alkali burns and was blind because of that. The donor in such a case, in his case, was a live donor who was an 11-year-old boy who had lost his vision because of scleral injury, and both eyes were transplanted at the same time, and one eye failed within a couple of weeks and the other eye survived for a few years. So from this success and failure both, going forward, all the ophthalmologists along the in the entire world worked hard and did a lot of research to look at the outcomes and how do we define keratoplasty, and how do we assess which is going to be a better case or not. So just showing you a few results from different places across the globe. Manchester Royal Eye Hospital reported an overall 5-year graft survival of 82%, with keratoconus and corneal dystrophies having the highest survival. And the rate of graft failure from they said the rate of graft failure from any cause is highest in the first 3 years of follow-up after penetrating keratoplasty. Now coming to Indian scenario, Joshi et al. Reported a median graft survival of 27 months in a retrospective series of 181 patients, with poor survival of 14 months in patients with poor prognosis. The 1 year and 2 year survival rates in this study was 65 and 52.5% respectively. Another big study conducted in Singapore from the Singapore Corneal Registry. It was a 16-year prospective study which studied 2,100 consecutive corneal transplants performed between 1991 and 2006. And they gave survival rates separately for optical grafts, for therapeutic grafts, and tectonic grafts. And they said that endothelial rejection and late endothelial decompensation accounted for about 50% of failures. I will be discussing later on about what's the difference between a rejection and a failure. So a penetrating keratoplasty, another study from UK where a single corneal unit was compared to the national data, and they found that the overall survival rate was 66% at their center and 98% was for keratoconus, and it subsequently decreased for different pathologies and was one of the lowest for regraft, that is 55%. Now, Gleason et al. Went on to study outcomes of repeated penetrating keratoplasty, and they found that for a pathology like keratoconus, where we had primary outcomes as good as 98%, there was a threefold decrease in the survival chances of a graft if a resurgery was needed, the risk of failure doubled in Fuchs endothelial dystrophy regrafts. So now from all these data, we know that the risk of keratoplasty failing, or I should say the chances of survival, changes. Any time, any day you advise your patient a surgery, the first question they have is what is the success rate? Unlike the usual cataract surgeries, keratoplasties of different types and different patients have different outcomes, and your patient has the right to know what kind of outcome he's going to have after the surgery. So that is why we need risk stratification. To emphasize more on it, from the Australian Graft Registry, we know the 10-year survival rate for keratoconus is as high as 89%, and for Fuchs is 73%, and it goes down to 40% in pseudophakic and aphakic corneal edema, and is as low as 37%. Only one third of the regraft survive till 10 years. So they defined certain high risk conditions, and they said that the survival rate drops to 30 to 50% at 3 to 5 year follow-up. Basitsky et al. In their study on repeated corneal grafts noted that only 28% of the 78 regrafts remained clear at the end of follow-up of 54 months. And this number dropped to 20% for a subsequent regrafting. So as we go on increasing the number of grafts, the survival rate keeps dropping. Now, the next question that comes to mind is what CCTS said long back. Is it enough? Is it the complete definition of a high risk graft? My answer to that is no. Reason being, they said just 2 or more quadrants of vascularization. So you can have a single vessel at 11 o'clock and another vessel at 8 o'clock. So you'll have 2 quadrants of vascularization. Vis-a-vis, there's another graft like this, which has more than one vessel in a quadrant, will be at a higher risk. We know that. So Bali et al. Defined in their meta-analysis the high risk graft as a transplant which had 2 or more clock hours. So the difference being here the clock hours and not the quadrants. 2 or more clock hours of corneal vascularization, or a previous failed graft, or a graft they included because of herpes simplex keratitis. Because the herpes simplex keratitis, we all know, is a continued inflammation. The inflammation keeps happening again and again. So the vascularization keeps on increasing. So a graft which is being done for a pathology because of herpes simplex keratitis will be a high-risk graft in most of the cases. The other conditions that place cornea at a higher risk of rejection include the position of the graft close to the limbus. Why so will come later. We'll discuss in the immunology subsequently. And simultaneous limbokeratoplasty or a severe atopic dermatitis for the same reason as repeated episodes of inflammation, and herpes simplex keratitis as I described. So a collaborative corneal transplant study based on their results gave out certain cues to as which graft is going to be high risk and which is not, and they defined the survival rate. So they said the survival rate depends on the indication of the graft. So keratoconus in their study showed the best survival. The graft numbers in the epilateral eye, as they kept on increasing, the chances of survival decreased by 1.2x in the study. The corneal vascularization at the time of graft, so if the vascularization was more, the chances of graft failure were more. And the presence of anterior synechiae because of the iris coming in contact with the corneal graft. So here it is important to understand the iris, if it is coming in contact with the host, will have increased chance of glaucoma, whereas iris which is coming in contact with the graft will have increased chances of rejection because of the iris vasculature, which brings in the antigen presenting cells and subsequently causes the immune response of rejection. The history of previous increase in intraocular pressure in the presence of aphakia or pseudophakia. Aphakia any day has more chances of failure as compared to pseudophakia. If there's any history of previous intraocular surgery like a vitrectomy or something, and a recipient who's young, who's less than 40 years of age, has higher chances of rejection or a failure. And the graft size, which is smaller than 8 millimeter, also has increased chances of failure. Now, the risk stratification can be simply done based on vascularity as low risk, medium risk, high risk, depending on the number of quadrants involved. So a low risk will be an avascular graft-host junction. Medium risk will be 1 to 2 quadrants of vascularization. High risk will be 3 to 4 quadrants of vascularization. A better and a more comprehensive way of stratifying the risk is based on the prognosis, as we know from our studies. So a category 1 will involve non-inflammatory conditions you can see as keratoconus, lattice dystrophy, and early Fuchs dystrophy, and they have an excellent prognosis of more than 90% success rate, and they will be categorized as low-risk grafts. Whereas the category 2, which includes pseudophakic bullous keratopathy, aphakic bullous keratopathy, or herpetic keratitis early cases, macular dystrophy, they come in moderate risk grafts. And category 3 and 4, more or less, these involve highly inflammatory conditions where the chances of vascularization are more. As you can see, chemical injuries there, dry eye or active keratitis, corneal opacities, and going down the ocular surface disorders. These are all a poor prognosis grafts, and they will be categorized as high risk grafts, and we need to take extreme caution when we are doing grafts for such patients. So any high risk graft, my advice to everybody will be, do not operate. As we all know, a good surgeon is the one who knows how to operate. A better surgeon knows when to operate. The best surgeon knows when not to operate. So in a high risk graft, we have to be really cautious. We should be doing a corneal graft only when it is really, really needed. For example, a patient who's young and blind by both eyes, yes, he needs a graft. And we have to take certain precautions and measures to reduce the chances of graft failure or graft rejection, and do take certain steps so that the survival rate of the graft improves. So high failure rate in such cases because of the high rejection rate, and as we have been discussing till now, all the grafts, all the conditions we labeled as high risk have vascularization in some form or the other, which brings in the which makes the cornea to lose its immune privilege it has. And there is certainly a role of systemic immunosuppressions in such cases with long-term cyclosporin A or mycophenolate mofetil, which may be needed to improve the survival of the graft, and they act so by restoration of the immunological privilege. So in various studies, mycophenolate mofetil has been found to be as effective as cyclosporin in preventing acute rejection following high-risk corneal transplantation. Another high-risk condition we have been talking all this while has been herpetic keratitis. So in this study by Goodfellow et al., they found that the patients receiving oral antivirals were less than a third as likely to have a failed graft at 5 years compared with those who did not receive any antiviral medications in the perioperative period. So this was the first part. So any doubts till now?
Any hot seaters, Raziba, Saloni? Any one of you have any doubts?
Sir, what is the reason for the increased risk in asphyxia?
Can you please repeat? You're not audible.
Sir, in case of aphakia, why is there an increased risk of rejection, sir?
So that's because of the vitreous, which is in contact with the iris. Vitreous contact with the endothelium leads to the failure of endothelium, that leads to increased risk of graft failures and causes a continuous inflammation.
Thank you.
Sir, I have a doubt, sir. So the
Yes.
graft size should be smaller. It should not touch the limbus. You have mentioned it now, sir.
Yes.
But in the risk factors, you have said the graft size, if it is less than 8 mm, it's a risk
Yes,
factor.
it was an observation in the study that the smaller grafts also had a higher chances of failure as compared to this. So the ideal graft size will be a moderate size graft, which is not as big as involving the limbus because and not less than 8 millimeters.
Okay, sir. Thank you, sir.
I think we are done with the good doubts, sir. We can go ahead.
Okay. So coming to the next part, the immune privilege I've been talking about, and I will be talking about in the rejection as well to understand rejection better. So immune privilege in cornea has been described by Nidecon as a three-legged stool, and the three legs being the afferent arm, the central arm, and the efferent arm. So what are these? So the afferent arm is basically the absence of antigen presenting cells or the inability of antigen presenting cells to reach the processing organs, which includes lymph nodes and the central organs like spleen. So this is achieved by blocking by the following mechanisms as listed. So avascularity and lack of lymphatics, that has become questionable now, the lack of lymphatics, but there have been animal studies which have shown that if there are no lymphatics and the vessels are present, still the chances of rejection decrease by about twofold if the lymphatics are absent or are knocked off in animal experiments. And another important thing is that there is low major histocompatibility complex expression in the corneal stromal cells, and there is presence of native immune suppression molecules as well in the cornea, which constitute the afferent arm blockade, the first leg of the stool. The second leg is the central arm, which is basically deviation of the immune response to a state of immune tolerance, and also known as anterior chamber this deviation, and it is done by clonal deletion, energy, and immune deviation. So in this, what happens is basically the effector arm is blocked by the protective molecules like fast ligands or programmed death ligand 1 and T regulator cells and T cell apoptosis, as you can see. So because of these these ligands present on the endothelial cells, the T cells which come in contact from the aqueous to the endothelium undergo either apoptosis or the T regulator cells are destroyed. And when you are doing the surgery, during the surgery, there are always alloreceptors which are which are secreted into the aqueous, and these go through to the regional lymph nodes and then they are suppressed there. So one important aspect of why we see increased immune rejection or a graft rejection in cases of when you take a eccentric graft, either the eccentric graft donor or a eccentric punching of the host. So whenever you're doing this, you should always remember the number of Langerhans cells are more in the peripheral cornea and they are enriched in MHC2. So that increases the chances of rejection in such cases. And the transported corneal alloantigen lead to a clonal expansion of T cells in regional lymph nodes and spleen. And this is the main mechanism through which IVMP acts, which I'll be talking about later on. So one of the important questions asked to any PG during a Viva is what is the difference between a graft failure and a graft rejection? The simple answer to that is the graft failure is something which is a failure of the graft for which it was actually performed. So a graft can be performed for either visual function, which is called an optical graft, or a therapeutic, diagnostic, or tectonic, or a cosmetic purpose. So just to give you an example, you can have a graph which is absolutely clear, but you have so much of irregular astigmatism, patient is not regaining any vision. So, and that graft was done in a case of keratoconus. So that is basically a graft failure from the visual point of view, and it will be labeled as a secondary graft failure. Now, at the same time, you have a graft which has edema, has had endothelial rejection, but is still appearing clear, and that graft was done for cosmetic purposes. Now, this graft will not be labeled as a failed graft. It is a working graft. It was done for cosmetic purposes. It is doing its job. So, graft failure in a simple way is failure of the graft to do its job for whatever reason it was done. Now, a graft failure can be further divided as primary or a secondary graft failure. This is a very arbitrary differentiation. Primary graft failure is basically in the first few weeks after surgery and is defined as a graft which never cleared after the surgery. So it is, you are expected to wait for about 4 to 6 weeks before labeling a graft as a primary graft failure, and its incidence is, I believe, is decreasing as per the old studies is 5%, and the risk factors involved in this are prolonged death, enucleation time, poor endothelial count, aphakic or a pseudophakic donor, a elderly donor, inadequate preservation, surgical trauma, HSV infection. So you can very well notice that I have not included anything related to the immune response. So this is not because of rejection. There is no immune reaction involved in a primary graft failure. And it is mainly because of the donor related issues. So the prevention henceforth will be a proper donor selection, good preservation of the donor cornea, avoid endothelial injury preoperatively and during the surgery. For example, we always have to put a visco or something on the endothelial side before we put the graft onto the host bed. And it should be observed for 3 to 4 weeks to clear, as I said already. Now, graft failure is more or less synonymous akin to a secondary graft failure, and there can be multiple causes of it. One of the cause is a graft rejection. So the causes of graft failure can be categorized as endothelial dysfunction can be because of the vascularization, which causes the graft to get some lipid keratopathy and it becomes hazy. The graft rejection is an immune phenomena, which we'll be discussing subsequently, or intraocular inflammation, which can cause again an endothelial cell death and then subsequently lead to graft edema. Then suboptimal donor tissue. For example, there may be a tissue which had a borderline cell count, will survive for a few weeks, will clear up, and then subsequently again you'll start getting edema and all the problems. So, and then trauma to graft during the surgery leads to endothelial cell loss. We all know there is different levels of endothelial cell loss during surgery, post-surgery, and a persistent hypotony, glaucoma, and vitreous or iris adherence to the graft brings in the antigen presenting cells, as I described previously. So amongst the different causes of graft failure, the most common cause is the allograft rejection, which accounts for about 30 to 50% of the graft failures. Now, the rejection is an immunological phenomena and can be divided in a case of PKP, penetrating keratoplasty is epithelial, stromal, endothelial. Now, you can have either one of them, all of them, or in any combination. Now, the next question that comes to mind is whether a graft rejection can happen in a lamellar graft or not. Yes, the answer is true. So, but you see the graft rejection corresponding to the part which has been transplanted. So in a DALC, you can see either a stromal rejection or epithelial rejection, and the incidence varies between 1 to 24%. And in endothelial keratoplasties, which are the most commonly ones done these days, are the DSEC and the DMEC. And in these, the endothelial rejection rate varies between 10%, 0 to 45% in DSEC. The DMEC, it is very low, up less than 1% has been reported. In DMEC, what we see more commonly is the primary graft failure. That is, the graft fails to clear in the first few weeks itself because of the increased endothelial cell loss due to multiple reasons. And in DMEC versus DSEC, it is believed that because of the decrease in the stromal tissue which is transplanted, the chances of endothelial rejection is low. A rejection, you can have describe it as either definite, probable, or possible. A definite rejection is the one you'll categorize your graft rejection as definite when you have a documented evidence the graft was clear previously, has developed a new onset anterior chamber reaction, has developed new onset keratic precipitates, and has an endothelial rejection line. Now, the same rejection can be labeled as probable if all the above findings are there, but there is no rejection line noted. And it will be labeled as possible when you have graft edema, but there is no evidence of any inflammation or any rejection line. Now, the risk factors for rejection are more or less the same as we discussed about the high-risk grafts. Young age, vascularization of the host cornea, large diameter corneal graft, as I've been saying, Langerhans cells are present more in the peripheral cornea, have more expression of MHC2, lead to increased chances of rejection. Iris synechiae, because of the iris vessels, which can bring in the immune cells and cause rejection, and the loose sutures can cause epi defect and subsequently infection and inflammation, which can lead to rejection and can also cause vascularization, which may lead to subsequently rejection. The prior graft failure, the risk increases from 8 to 40% over 3 years, as we discussed already. And the prior use of glaucoma surgeries and AGMs and pre-existing inflammation, as in herpetic keratitis patients. So how do you identify a graft rejection? It is very important to counsel your patients pre-operatively as well as post-operatively about the different symptoms of graft rejection, because the chances of graft rejection are lifelong once you do a graft. And the patient should understand that he has to report as soon as possible if he has these symptoms persisting for more than few hours as described in literature. So if the patient feels the vision has gone down as compared to previously, or been having red eye continuously, and or is having pain, discomfort, irritation, or photophobia, then he should know that he has to visit a hospital, because rejection is something that can be reversed. But if it persists for long and becomes a failure, there is no chance of recovering the graft, and then we have to do a regraft. Now, signs I have categorized based on the level of rejection you see. So in epithelial rejection, you see a epithelial line, which is raised line of epithelium, and it stains with fluorescein or rose bengal, as can be seen in this photograph. And this line usually represents the junction of the host epithelial cells and the donor epithelial cells, and this line progresses from the periphery to the center and then to the other side, thus replacing thus the host epithelium replacing the donor epithelium slowly over time. And now this line can be the epithelial rejection usually seen only within the first 1 year of the transplant, because by the end of 1 year it has been shown that all the donor epithelium is lost and has been replaced by the host epithelium. So there are very less chances of you seeing a epithelial rejection beyond 1 year of graft. Coming to stromal rejection, the stromal rejection can be seen anytime after the graft and can be seen lifelong. And the evidence to this is that the stromal cells in the graft are being replaced by the host cells. So there is a continuous interaction of these cells, keratocytes happening, and this is validated by the fact that there are certain corneal stromal dystrophies which do recur in the corneal grafts. Now, how do you identify a stromal rejection? Corneal haze is seen as seen in the photograph, or there may be Krashmar dots. These dots are actually small, hazy, discrete subepithelial infiltrates, which very much mimic the infiltrates post adenoviral conjunctivitis. And the circumcorneal hyperemia is a general sign, can be seen with any kind of rejection. And the circumcorneal hyperemia is actually the circumciliary congestion is the earliest sign of graft rejection, can be seen even before your loss of vision or your KPs or your rejection lines or anything. So the earliest sign of a graft rejection will be a circumciliary congestion. Now, coming to endothelial rejection, in endothelial rejection, you see keratic precipitates, which may be present as a linear line, which is known as Coda-Dost line, or a diffuse number of keratic precipitates present all over the graft. And there'll be associated interchamber inflammation in the form of cells and flare because of the leakage from the vessels in the interior chamber. Now, there is always a important one should give a lot of importance to the number of KPs present, because higher the number of KPs, more the chance of rejection and lesser the chances of survival of the graft. And one should know how to identify an old KP or a new KP. A new KP will have some volume to it, will have hazy borders, and whereas the old KP will be more of pigmented, well-defined borders and will appear as it's constricting. And the location of KPs becomes really important in a case where you have had a history of herpetic uveitis or keratitis, because in case this is the best way and the most effective way to differentiate between a graft rejection and inflammation because of the herpetic pathology. So in cases of graft rejection, the KPs will be present only on the area of the donor endothelium. Whereas in a case of herpetic uveitis, the KPs will be present also on the host bed. So that becomes an important sign to differentiate between the two. Another modality described for identifying early graft rejection is corneal pachymetry. So McDonnell et al. Studied the corneal thickness over many months post keratoplasty, and they found that the corneal thickness usually stabilizes by the third postoperative month. So it can be a marker which can be used for objective definition of objective identification of corneal graft rejection. So, and they also said that if the corneal thickness is more than 590 microns at the sixth post-operative month, there is a very high risk of graft failure in such a case. Monroe et al. Studied the specular microscopy changes, which also can present even before the inflammation, and this is being projected as a objective and early marker of rejection episode, although it's not very commonly done. But yes, we do specular microscopy for grafts every 6 months to 1 year to assess. So what are the differential diagnoses of a graft rejection? Can be graft failure. So it becomes difficult to sometimes identify whether the graft has actually failed or has just rejected, and there is a potential for it to revert and get there is a potential for the graft to become clear again. So in such a case, I'll always advise you should err on the side of rejection, give it a trial of steroids. If the patient improves, good enough. Otherwise, we'll have to label it as graft failure. So inflammation is presence of inflammation is one important thing that can help you differentiate between graft failure and a rejection. Failure will not show any signs of inflammation, whereas rejection will have significant amount of inflammation. Loose sutures, early microbial keratitis can sometimes be confused as a graft rejection because of the edema. HSV keratitis can very well mimic a graft rejection, as we discussed already. The epithelial downgrowths, and although it's very rare these days, can also mimic because of the downgrowth happens along the endothelial layer, and the graft starts appearing hazy and it's progressive. The best way to differentiate is to give a trial of steroids. The rejection will improve with steroids, epithelial downgrowth will not. So one has to always remember the risk of rejection is lifelong, and the best key is early diagnosis and treatment of graft rejection. And the importance of pre and post-operative counseling of patient about the signs and symptoms of graft rejection is very important. And the most commonly adopted treatment modalities, frequent topical steroids. I follow a regimen of hourly steroids for a week and then assess the patient and then accordingly taper the steroids slowly. And there is a role of systemic steroids, especially IVMP has been studied extensively about its role in graft rejection. So broadly, the treatment protocol followed by me is that epithelial rejection, just the frequent corticosteroids are enough. You don't need systemic steroids. And if there is endothelial rejection, there is a role of IV pulse corticosteroids, especially if the patient presents within first 7 days of the onset of graft rejection. And obviously, it has to be supplemented with aggressive topical steroids as well. Same way for the combined rejection and rejection in a graft which has already had one rejection episode. So these are some of the photographs of the patient who were managed. This patient had a DSEC and then was lost to follow-up and then came with these KPs. I had put this photograph in the endothelial rejection slide as well. Now this patient was given hourly topical steroids only. There was no IVMP given, and this is the outcome after about 6 weeks of therapy. This patient underwent a DALC for a keratoconus, had the stromal haze at one of the follow-ups with these dots, Krashmer dots. This patient was given IVMP, had presented within the first weeks, and you can see the graft clearing at the end of 2 weeks. So the role of pulsed IV steroids, it has been shown that there is a statistically less likely to have a rejection episode in the future as compared to those patients who received oral steroids. And a single pulse of IV methylprednisolone actually produces a relative lymphopenia, and it causes the T cells to stay in the organs away from the graft eye, and this persists for about 48 hours, but there is no significant benefit or improvement noted if you give a second pulse. So the regimen for this will be a 500 milligram single IV pulse, which is given if the patient presents, more beneficial if the patient presents within the first week. Up to 2 weeks, you can give IV methylprednisolone. So the future of the corneal graft rejection, we know the corneal graft rejection is a delayed type hypersensitivity reaction, which is primarily cell-mediated response controlled by CD4 T cells, and thus the use of anti-CD4 and co-stimulatory molecule blockade are the new approaches towards management of graft rejection, or we can simply go for a bioengineered corneal cell regeneration therapies in future for patients who are high-risk grafts. Thank you for your patient listening.
Thank you so much, sir, for the descriptive presentation, sir. It was really nice. So we have certain questions, sir.
Yes.
So the first question is that in patients who are immunocompromised in general, so what would be the regimen that you would like to keep them on to avoid the chances of graft rejection?
My regimen for any patient, see, as we discussed already, there is no role of systemic per se in a patient who has a low risk graft. So if you have a patient who has no vascularization, you have labeled it as low risk graft, you do not need to give any systemic immunosuppression. You just give topical steroids as you give for a normal graft.
Okay, sir. So the next question is that how often do you see graft rejection in diabetic patients, and what should be the protocol while managing them?
I don't think the rate of rejection is different between a diabetic or a non-diabetic. The concern for managing such a patient will be whether you can give a systemic steroid or not. And a single dose of IVMP, if the sugars are controlled, will not cause much of a problem, I believe.
Okay, sir. So there's a question about thymectomy, whether it will help in preventing graft rejection, sir.
So the corneal grafts are actually, grafting is actually one of the most successful kind of human transplant you have. I think going for a thymectomy will be a long shot because the mechanisms we have in place like ACAID and the effector arm suppression of the clonal suppression, everything, thymectomy is not going to help much.
So
in
your
my-
voice is not clear, sir.
So I was saying that I'm not in favor. I don't think thymectomy is going to help much in a case in preventing graft rejection. As such, the corneal graft is one of the most successfully done graft for human body, and the chances of, because of the different mechanisms in place as I described in immune privilege, thymectomy is not going to add much.
Okay, sir.
Will be a bit of a overkill according to
Okay,
me.
sir. So many postgraduates get confused between graft rejection and graft failure. So I would really request you to please explain that to them, because I am sure that even some of my juniors had the same problem. So it would be really nice if you
So
could tell them.
I'll re-explain what I said during my presentation. So rejection is something which is reversible. Graft failure is something which is not reversible. Graft failure is basically defining a graft which was done for some purpose and is not able to serve that purpose. So a rejection, whereas, is an immune phenomena, and rejection can lead to failure, and it is one of the causes of graft failure, but is not the only cause of graft failure.
Okay, sir. So could you also please explain the ACAD mechanism, like ACAID?
So what happens is while you're doing the surgery or even after surgery, the donor alloantigens are being exposed to the aqueous all the time. Now the normal phenomena will be that this alloantigens will get presented to the lymph nodes, and then there should be a response. Whereas in anterior-chamber immune deviation, what happens is this system gets deviated, and there is suppression of the immune response to the alloantigens which are present in the aqueous.
Okay, sir. Okay, sir. So one more question is that in what are the factors that are most commonly responsible for graft rejection in the donor tissue? Like, out of all the factors that you have explained, which are the most common ones that you see?
Can you repeat your question once?
So what are the most common factors that you see when it comes to rejection in terms of donor cornea?
So a donor cornea, so there are certain particular things that we need to see. Donor cornea should be assessed properly before when you get the cornea. So during assessment, what you need to look at it is if it is a pseudophakic donor, what is the age of the donor, how much was the time to enucleation, basically all the factors that I described for primary graft failure. So all these will come into play when I look at it. But once a graft clears, it does not, practically speaking, it does not make much of a difference.
Okay, sir. Sir, when should keratoplasty be done in bullous keratopathy patients?
I think the current modality of choice for a pseudophakic bullous keratopathy is not a keratoplasty, which is used for penetrating keratoplasty. A DSEK or a DMEK is the preferred modality. And whenever the patient is symptomatic and has continuously bullae forming, that is the time when you should go for a keratoplasty. And the edema has not been clearing up, say, a post cataract surgery for more than 3 months.
Okay, sir. So there's a question that how is the time of enucleation related to rejection?
It's not related to rejection, it's more related to the failure of the graft, because as the time of enucleation, the time to death, time of enucleation post death increases, the endothelial cell loss starts increasing, and if it is more than 6 hours, there are high chances of primary graft failure.
Okay, sir. So another question is that stored cornea is better than fresh corneal tissue? If yes, then how does it help? One of the online panelists, they've asked this question.
No, I don't think the fresh corneas are not. I mean, fresh corneas are always better. The earlier you use the graft tissue, from the donation time to enucleation time to usage time, it should be as low as possible.
Okay, sir. So, in detail, could you describe what precautions are to be taken in pediatric cases specifically?
In pediatric cases, there are certain surgical challenges that you face, and there are certain post-operative challenges you face. So during surgery, the dissection is a little difficult, and the suture removal. So coming to post-surgery, what happens is basically they have a very intense immune mechanism, and there are they get grafts are at a higher risk of vascularization very early. So the sutures should be removed relatively early as compared to the older patients. And you need to do regular examinations under anesthesia for pediatric patients and look for any loose sutures, because the healing response is faster. There are chances of sutures getting loose even faster than the adult transplants. And there is a difference between how the rejection presents in such cases. In pediatric cases, what has been seen is that the patient can frequently present with a epithelial defect which was not there previously, instead of inflammation.
Okay. So, what would be the reason for the epithelial defect mostly? Like just the.
Sure about that.
Okay, sir. So, another question is that how do manage marginal ulcer cases? Like, since it would come at the interface.
So a marginal ulcer can be managed with a small patch grafts if there's a perforation, or if this perforation is small, then just a glue BCL. If it is large enough, then maybe a patch graft can be done.
Okay, sir. So one more thing is that how many sutures are ideal for a good graft, and what clockers do you prefer, sir? So it's I know it's surgeon specific, but what is your choice, sir?
So I do 16 sutures and do 24 if the graft is more than 10 but otherwise 16 sutures, yes. And clockers, I didn't get the question. It has to be equally distributed.
Yes, sir. Like, could you explain to the viewers that
So
how
the suturing technique in interrupted sutures will be to take a first suture at 12 o'clock, followed by a radially opposite 6 o'clock, and then the two sutures at 3 and 9 o'clock. They form your four cardinal sutures, and then equally dividing each quadrant in the form of taking radially opposite sutures. So if you're doing between 12 and 3, take one suture, then take the other suture opposite between 6 and 9. And same way on the diagonally opposite quadrants, and then between the spaces are filled with the sutures. Yes.
Right, sir. So I'm sure that you must be coming across this next question very often these days. That in COVID era, what are the precautions that you are taking, and how is it affecting the donor selection criteria?
So for as far as I think we are not getting tissue so easily, and home-based donation has not been allowed yet. Only donation we are getting are from the hospital-based retrieval programs. And during the surgery, pre-operative COVID testing for the patient is being done, and then subsequently, I think most of the aqueous is being replaced by the viscoelastic at the start of the surgery. So not much of an issue.
So, what is the role of cyclosporin A and tacrolimus? One of the panelists want to know this question.
So they can be helpful in cases where this patient is having issues with the steroids. They are having glaucoma, and when the IOP is rising because of the steroid use. And in high risk cases, yes, they do help in increasing the graft survival. So cyclosporin can be given twice a day continuously, in addition to a baseline dose of OD steroid in a case who has undergone multiple grafts and is a precious eye, the only seeing eye of the patient. Yes, I would like to give cyclosporin.
Okay, sir. So one more question is that if you're planning to do a penetrating keratoplasty and it is mandatory to do it in a patient who has a vascularized cornea, what precautions are to be taken, sir?
So if first of all, we need to find ascertain why there is vascularization. If it is because of the herpetic scar, then we need to start the patient on acyclovir preoperatively and continue it through the surgery and after it as well. And other than that, yes, in certain cases where you have done multiple grafts and it's been rejecting again, there are certain studies which do show some effect of some benefit of giving anti-VEGF before doing the transplant. Multiple subconj injections, 3 to 4 injections are given, and then subsequently a transplant is done.
Okay, sir. So in post-operative cases, when you have to prescribe anti-glaucoma drugs, what is the regimen, and when should we start it and when should we stop it?
In post-operative routine regimen, I'll not be giving any anti-glaucoma medication topically. I just give my patients Diamox for a couple of days because there may be some retained viscoelastic. Otherwise, I am not using any post-operative per se medication for just the pressure control. If the pressure is high, yes, I'll definitely not be using prostaglandin analogs, and I prefer using a timolol over other medications.
Okay, sir. So after suture removal, how long should we wait for prescribing the glasses to the patient?
So I usually see my patients after 4 to 6 weeks. Call my patient, in fact, after 4 weeks only once I remove a suture, and then assess if I need to remove more sutures or not.
Okay, sir. So one of the panelists wants to know that what is the role of basiliximab in graft failure?
I have no personal experience with the medicine, so sorry, I won't be able to comment on that.
Okay, sir. So these were all the questions that we had, and you'd already described most of the things in your presentation, sir.
Thank you.
So thank you so much, sir, for being there. So would you like to ask some questions to the hot seat panelists? They're all here. So you please feel free to ask them questions, and they'll be happy to answer.
I think probably not a good time to ask them questions right now. Maybe some other time.
Any of the hot seat participants, if you have any questions, you can ask, sir. Any questions, hot seat participants?
I think mostly they've posted their questions, and
Yeah, all the questions are, there are
Yeah.
no more questions. The concept is very clear. Sir has covered it very extensively. Thank you so much,
Thank
sir.
you,
Thank you,
Harika.
everyone,
Thank you.
for joining us. And please be there on November 6th. So we have the much awaited speaker, Professor Namrata Sharma, who will be speaking on anterior lamellar keratoplasty. Thank you so much. Good night.
Thank you. Good night.
Good night.